So today I'd like to share with you some of the nuances and important clinical considerations when we're choosing CRT lenses versus MiSight to manage pediatric myopia. We know these two treatments serve as a complement to each other, and we're hoping with both options available, we're able to serve a broader range of patients with a better long-term outcome in both safety and efficacy. By the way, I have two corgis. I drew this picture myself. You can see this is pretty much all of the available evidence-based options we have in US. So let's start with this case. So this is a 10-year-old Asian boy coming to our clinic, and parents are very motivated to start myopia treatment. The boy had very poor compliance with glasses. Out of the numerous visits I saw him, he never worn his glasses on his face. It's always in his pocket. Mom is high myopia, dad is low myopia. Neither of them had any previous history in wearing either soft or hard contact lenses. And the reason I want to mention this is because parents' history in wearing contact lenses and whether they're successful or they absolutely hated it made a huge impact on their decisions in choosing either the overnight lenses versus the daytime soft lenses. So the boy came in with reduced vision because of his fast progression. His glasses were a little bit old, but it's cooperating with what we're seeing here. Even within a limited time, he has a noticeable clinically meaningful progression. And for anybody sitting in this audience, I'm sure everybody would feel, based on the level of myopia and his corneal curvature, this should be a pretty straightforward ortho-K fitting. But I want to draw your attention to his binocular status. He has 20 prism diopters of a left intermittent exotrope at distance, and at near his aphoria. And so whenever we're considering ortho-K or MiSight lenses, we really want to think about what would be the impact of the huge amount of higher order aberration and sometimes under correction we're introducing to the patient's visual system, and whether this presents a long-term outcome in terms of the visual performance or the patient's stereopsis. Fortunately, at near, without correction, he has pretty good stereopsis. So I want to use this case to bring up some discussion here. In terms of a BV test, we know it's been commonly reported that progressive myopes tend to present a pretty large lack of accommodation, and many kids presented with axophoria or sometimes an intermittent or constant exotropia. But we also want to think about how we measure BV status in those patients. As I mentioned earlier, because of their fast progression, many patients are evaluated under a brand new prescription, but this is not what they're used to. They're used to either not wearing their glasses or wear an under-corrected pair. So if they're not fully corrected, and we found a significant change in the prescription, we used a new prescription to measure their accommodation, no doubt they're going to have a lack of accommodation. So is this representing the true performance of the patients? Or we should actually give the patients the updated prescription, let them adapt, and then re-evaluate their BV performance. And in terms of the stereo acuity, I use this as a very important feature in understanding whether the additional higher order aberration or sometimes defocus signals are introduced to the visual system. How is that going to affect the patient's visual performance? If I'm seeing a patient with either a constant troping, whether it's just one eye or it's bilateral, if patients have reduced visual acuity, stereo acuity, I would focus more on improving the sharpness of vision and making sure I'm creating an optimized visual environment to maximize the depth perception. And so this is a very important consideration when we're feeding, especially feeding ortho-K lenses, which I'm going to come back in a little bit. And in terms of the patient's exotropia, if this is constant versus intermittent, our goal in maintaining a normal or improving on the BV function versus our goal in managing myopia progression the priority can be quite different. If the patient is presented with alternating or unilateral exotropia, obviously the impact on their BV status is also different. So in general, I'm not too concerned if the patient is only an intermittent, especially if it's an alternating exotropia with a good near stereopsis. We know in those cases, patients able to fuse and maintaining pretty precise binocular coordination in most of the distance or more so at near. And in terms of their amount of troping at distance or at near, whether it's the A pattern or the V pattern, that has a lot to do with how we want to change the Jensen factors or change the add power of the multifocal lenses. So for this patient, apparently a pretty easy patient, either to go with MiSight or with Ortho-K, I do want to make sure I carry all of these considerations when I see patients for their follow-up. For any patient with either intermittent or constant exotropia, and I usually try to avoid any level of undercorrection. So if anything, when I'm feeding Ortho-K lenses, I tend to full correct or sometimes a slightly overcorrect patient in the morning. And in terms of the follow-up, I do want to see patients in the early stage of feeding in the morning, but I want to see patients at least for a couple visits in the late afternoon to understand a little bit better the potential visual regression and the impact on patients' BV status. In terms of measuring the amount of undercorrection, we know anybody undergoing Ortho-K treatment, because of the significant aberration we have introduced on the corneal surface, we are going to see a huge difference in terms of the autorefraction versus the manifest or the subjective refraction. And in terms of understanding the exact amount of undercorrection, we are going to use the subjective performance rather than on the autorefraction, which tends to overestimate the actual amount of undercorrection. And I do want to repeat a very comprehensive BV test after the treatment has stabilized. If we were to use multifocal lenses such as MiSight for this patient, I'm not too worried about patients using the add region of the lenses for near vision. There are some doctors a little bit concerned. They're thinking, oh, if we prescribe the lenses with an add power, and if kids are actually using the add power for near vision, is this going to make their exotropia worse because they're not utilizing accommodative convergence at near? And the answer is no. Most of the kids with ample accommodative amplitude, they still look through the distance region of the multifocal lenses at near. And to my experience, I haven't seen any of the dual focus or multifocal soft lenses worsening the patient's exotropia or exophoria at near. And for multifocal lenses, I tend not to over-minus the patient's distance power for more than half diopter. So if the patient full prescription at corneal plane is minus 350, the maximum power I give in the multifocal lenses is minus 4, and which we're going to come back in a little bit explaining why when you need to add a lot of over-minus to bring a decent distance vision, that's usually a design or fitting problem. It's not something that should be addressed by increasing the minus power. And in terms of low-dose atropine, the impact of low-dose atropine on the patient's BV performance is very unpredictable. It's highly dependent on the exact concentration of the atropine we use. If the patient uses a lower concentration of atropine, it's only reducing the accommodative amplitude slightly, so most patients actually accommodate harder. And in those cases, if they have exotropia, it's actually helping with their exotrope. But if we're using a very high concentration of atropine, completely cycloplegic the patient, their accommodative system eventually just give up. In those cases, we may see a worsening of their exotrope. And so for that reason, I tend to stay away from low-dose atropine if I see patients have significant BV issues. So the take-home point for the first case is to really show you that exotropia is actually very common in progressive myopia, especially in those who have very poor compliance with their glasses. They are used to wandering around without clear vision. They're not used to using their minus correction to drive the accommodative convergence. And so in those cases, we do want to prioritize in giving them a good distance vision so that they have a clear visual cue to guide the precise fixation of the vision. And in BV, binocular vision doctors, for anybody with exotropia, a common strategy is to give patients an over-minus prescription, whether it's an over-minus the single vision glasses or single vision contacts. It is pretty clearly demonstrated that over-minus is an increased risk factor for faster axial elongation and myopia progression. So in these cases, I do not recommend over-minusing either in a ortho-K treatment or in a multifocal treatment dramatically. And as we mentioned earlier, kids with a very good range of accommodation usually do not accommodate or view through the ad portion of the lenses at near. So there is very little concern of the kids not able to utilize accommodative convergence when they're looking at near. And this is very different compared to the novel spectacles on the market. We know in Asia, especially in mainland China, there are over 250 designs in the novel spectacles. Even though a lot of doctors call them defocus glasses, but the micro lenslet in those novel spectacles actually are not image forming because all of these lenslets, they're not coaxial. They do not share the common axis. So for each individual lenslet, even though they're able to form an image, but on the visual system, they're not able to form a separate image plane, separating from their distance correction. So in these cases, patients do not have the option of look through the micro lenses for any other distances. They're all relying on the distance power. And also from the novel spectacles, we have learned that myopic defocus is only one special type of a myopia stop signals. There are many other types of stop signals. Most of the novel spectacles do not have any myopic defocus as their dosage for myopia control. They're either higher order aberration or pure toric lenses. Some of them reduce contrast, some of them just reduce the retina's ability to pick up the gold signal. So let's be more comprehensive in only considering the myopic defocus as a special type of the myopia stop signals. And lastly, try to avoid significant undercorrection in ortho-K when we're seeing patients either presented with constant or intermittent exotropia. Very quickly, I want to mention something about a very common misconception. We have heard many doctors and even seen multiple publications showing that myopia, if we start ortho-K at lower level, the controlling efficacy is not as good as the fitting ortho-K lenses in moderate to moderately high myopia. This statement is actually false. Number one, let me share with you the data we have published the last year from our UC Berkeley Eye Center. At our eye center, we use almost exclusively CRT lenses. So on the plot on the left side is clearly showing you the overall increase in axial elongation is independent of the patient's baseline level of myopia. Whether the patient is a low myopia or is a moderate myopia, we get the same amount of axial inhibition. But on the right side, if we see the plot of the axial length change as a function of the patient's baseline age, we see a very clear negative correlation in which the younger the patient at the baseline of ortho-K treatment, the faster the axial elongation. And so the previously reported apparent correlation between lower myopia not getting sufficient controlling effect is due to the confounding between the level of myopia and the age at the baseline of treatment. Those having the lower level of myopia happen to be also the younger patients. And younger patients we know for two factors. One, the younger the patients, the more of the physiological axial increase every year. Second, the younger the age of onset of myopia, they tend to be the faster progressor, whether you're using ortho-K or multifocal. So after adjusting for the baseline age of the treatment, low level of myopia receive the same efficacy as moderate myopia for ortho-K lenses. And this is basically a ranking of the axial length inhibition of all of the studies published up to last year. And for CRT lenses, which is almost all of the lenses we use at Berkeley, we're not seeing a lens or design-specific difference in terms of the controlling efficacy. And we also started hearing some manufacturers claiming that some lenses work better in a myopia-optimized or myopia control-optimized design. At this moment, we just do not have enough evidence showing which design has better myopia control effect compared to other designs. But I do want to mention that for ortho-K treatment, regardless of the ethnicity of the study subjects or the age, we see this huge individual variability. With the same treatment, same doctor feeding the patient, we see there's a huge difference in terms of the patient's response to the treatment. Some patients just have almost no progression, but some other patients almost progress nearly as fast as compared to a single vision control. So we as doctors, anytime we see this huge individual variability in the same treatment, we need to be cautious of applying an average efficacy into each individual case. So to summarize on the ortho-K part, the exact controlling mechanism of ortho-K lenses for myopia or axial inhibition is actually not very clear. We thought it was related to a peripheral or myopic defocus, but based on our evolved understanding from the novel spectacles and some of the other soft lens design, we know the myopic defocus is only one of the many controlling mechanisms. And don't be discouraged in fitting lower myopia. The lower the level of myopia, the easier the fit, the safer the treatment, the less risk of a corneal complication. And younger patients, in my personal experience, younger patients who are not able to handle lenses independently with a very low level of myopia are probably an ideal group of candidates for ortho-K. So this case is a typical case we would consider for MiSight lenses. This girl is an Indian girl as a semi-professional dancer. She also has a very poor compliance with her glasses. And mom had really good experience with her daily disposable lenses. And because of her high critical visual demand, because she's almost going into competition multiple times every week, parents are very concerned about potential fluctuation of the vision, especially in a long-haul flight. If she's not able to wear the ortho-K lenses at night, her vision the next day during the competition would not be very good. And so considering the parents' own successful experience in daily disposable lenses and the kids' high critical visual demand, and we fit her in the multifocal lenses. So here are some common factors I would urge you to consider when we're thinking about selecting patients for MiSight lenses. Strong motivation to be glasses-free is, to me, the #1 predictor for long-term success. The stronger the motivation, the more the effort they're willing to put in to make sure they can learn this application removal of the lenses as quickly as possible. And the level of myopia in general, I'm biased toward MiSight lenses for moderate and high myopia. This is just because these lenses provide much better and much more consistent vision. There is no need of, in case I can't wear ortho-K lenses tonight, my vision will be blurry the next day. I have 10 pairs of glasses. This is for one night of not wearing the lenses. This is for 3 nights of not wearing the lenses. All of that trouble. And for patients with the same level of myopia, with a flatter cornea, MiSight will be a much viable long-term option because the chance of these patients being washed out from ortho-K in the future in case of a suboptimal controlling effect is much higher if the patient has a flatter cornea to start with. Very quickly, fitting multifocal soft lenses, even though the fitting process itself is very quick and simple, but comparing to fitting a single vision soft lens, there is one more step I urge our colleagues to pay attention to. We know in single vision lenses, the whole lens carries the same optical power. So if the lens is slightly decentered, the impact on vision is very, very small. But if we're fitting a multifocal or dual focus lenses, a small decentration of the lens may have a stronger impact on the visual performance, especially if the direction of the lens decentration is different than the pupil's barycenter. So in this case, we know to my knowledge, most of the multifocal soft lenses have their multifocality built on the front surface of the lens. So in order to really understand how are the optical zone of the lenses aligned with the pupil region, it's very easy to perform on-lenses topography to get a really good understanding. Ideally, we want the lenses to fit not only centered on the cornea, but also centered over the pupil region. But this may not always be the case. For example, this on the left side is showing the pretty optimal centration of the lens on the cornea under the slit lamp evaluation. But you can see because the pupil is not perfectly centered, once we ask patients to do topography along the visual axis, you can clearly see the misalignment between the pupil region and the center distance optics. And in this case, in case you can't really see the edge of the lenses, this is the worst combination. The lens is decentered out and down, but the pupil is decentered nasally and superiorly. So once you perform topography along the visual axis, you see a very significant misalignment between the lens optics and the pupil region. So patients with this type of a fitting combination is likely to experience more ghosting and glare. Sometimes you need to increase the distance power dramatically to give patients a reasonable distance vision, but in that case, you are negating all of the myopia stop signals by over-minusing the patients too much. So if this is the case, you may want to switch to a different design. And if it's too hard to really see the centration of the lenses, I know some doctors actually rely on staff to do that. You can do a very faint fluorescein staining on the trial lenses, making the fitting of the lenses a lot easier to evaluate. Very quickly, I want to share with you our 5-year perspective in using the MiSight lenses. Some doctors in Asia is concerned about the generalizability of the MCT in MiSight preclinical study because it's very heavily biased toward white ethnicity. So in our clinic, I'm showing you the average patients at the age of our MiSight patient is a little bit older than what's reported in the MiSight clinical trial, but we have a much wider age distribution of a MiSight patient. And in terms of the ethnicity, the majority of our MiSight patients are actually Asian. And the baseline level of myopia, because we fit a lot of our younger patients in Ortho-K, and so you can see by the time we start them in MiSight, the average baseline myopia is slightly higher than what was reported in the MiSight RCT. So overall, in this 5-year summary, we're seeing a pretty comparable inhibition, both that evaluated with the change of refraction as well as the change in axial length. And so the purple is what is reported in the MiSight multi-center trial. You can see for both the first year and 2 years cumulative, we're getting at least non-inferior performance in the axial inhibition and the myopia control. The MCT reported about 41% of the patients showing no progression. We actually have a slightly higher percentage on that. And in terms of the axial reduction, we do have 23% of our patients showing a transient shortening of the axial length. Even though this may not be persistent, but we consider a small transient axial reduction may be a good predictor of the patient's responsiveness in the future. And consistently, we're also seeing 17% of the patients showing a very small level of hyperopic shift in their refraction. So in summary, we know the overall ocular growth is highly regulated by the optical environment, but we actually don't know exactly what's serving as the most effective myopia stop signal. Many optical engineers like to use a retina where the modeling consider retina as the screen of a camera. But in reality, retina is nothing like the screen of a camera. Retina is evolved to be able to detect changes and contrast, whether it's the change in defocus, change in aberration, change in color, change in light intensity, much better than the absolute value. So instead of recording the absolute pixel value, like in the camera, retina only picks up changes. So we need to be more open-minded in trying to have a better understanding of what's the best myopia controlling signals. But in terms of the contact lens options, low to moderate myopia, younger age patient, I'm slightly biased toward ortho-K, but everybody else with a higher prescription, older age, more critical of vision, I'm strongly biased toward MiSight. We didn't have time to go over the bitoric multifocal GP lenses, but for those really complicated cases, -8 and -450 with the rule corneal seal, bitoric large diameter multifocal GP would be a really good option. But overall, myopia management is a long-term commitment. We really need to balance the patient's vision, the long-term comfort and the feasibility, as well as the affordability of the treatment. Thank you very much.